very similarly, I'm going to talk about some of the medical decision and indication considerations for spine surgery. I'm going to, 1 second, let me just start the slide from the beginning. So before I start here, my disclosures, while I have some financial relationships, there are no direct conflicts with the content of this talk. The objective of this talk is to provide some general considerations, information about general consideration and perspective for spine care from the perspective of a surgeon. And we'll go through some of the thought processes in making that decision and identifying some of the things that are related to more red flag and urgent indications to some of those that are typically more routine. And then finally, at the end of this talk, what we're hoping for is to get all the participants to give you some time to be a part of the discussion and have any of your questions or comments as part of this talk. So, just I would preface by saying this is, my, personal perspective. I think that many surgeons share this. I mean, from a surgical perspective, obviously, we're here to help the patient, and as surgeons, we are best in helping our patient when we can, consider possible spine surgery. Now, but it doesn't mean everyone that we see are going to get spine surgery. In fact, it's quite the opposite. As you probably heard, the data out there is that most people don't need spine surgery, and probably less than 5% of the patients I see on a routine clinic would ever come close to meeting a surgical indication. So fundamentally, when I evaluate someone for the possibility of spine surgery, or really just trying to figure out how I can help them, what I'm trying to identify are the patients, do they have any conditions that may need surgery? Do they have a condition that actually gets better with surgery? And then more importantly, I would say that most of the time we're spending our time trying to figure out who doesn't need surgery. And then even for those patients who may benefit from surgery and have the appropriate surgical indication, there are reasons we may consider what type of patients don't do well with spine surgery, even if they have the appropriate reason, the indication. So, the typical things for people that generally may require surgery are fairly simple. I mean, I think that they are pretty obvious indications. One is whenever there is severe spinal cord compression and progressive motor-sensory loss. In some situations, severe neurocompression that are associated, again, with motor-sensory loss. Not necessarily for pain, but for motor-sensory loss. And then patients who have gross spinal instability, patients who have an unstable spine that may lead to ultimately neurological injuries, because one of the major reasons for function of the spinal column is to protect the spinal cord and nerve. So these are, what we would consider as, the more absolute surgical indications. When someone presents to us with spinal cord compression, they're not able to walk, and there's a pathology. Those are the patients we would highly, recommend consider surgery. So when we look at conditions that may get better with surgery, surgery doesn't fix everything. It certainly doesn't fix back pain without the appropriate reason. So, for the most part, the conditions that may get better are really that are acute or chronic conditions that are associated with either spinal cord or spinal nerve compression, because, as surgeons, we can surgically remove those lesions that are providing mechanical compression or mechanical insults to the neurological structures. We can improve patients who have spinal instability. So really, that's fundamentally the reason for spine fusion, is when someone is unstable, where they can have pain from the movement, or they're not protecting their spinal neural elements because of spinal instability. And then deformity is not necessarily spinal instability, but because of deformity and the changes to the alignment of the spine. Generally, a spine fusion is indicated to realign, reconstruct the spine in a alignment that's appropriate to minimize pain. And These are actually probably the more common indication and more common things we face with in an outpatient basis. And typically, these are what we would consider relative contraindication. Again, even if the patients meet these these indications, we still have to consider whether or not patients may benefit from surgery, and do they do well with surgery because of what needs to be done related to anesthesia or with our surgical treatment. So who doesn't need spine surgery? And I would probably say on average, most patients with acute back pain should not need spine surgery. And similarly, most people with acute radiculopathy should not need surgery. Very rarely are you going to have someone with molar sensory loss that is not reversible in patients with acute back pain with acute radiculopathy. The exception to the rules are generally the patients that present to the ER where they had a trauma, they have an infection, or they have tumors. I would also make the argument that most people with non-specific chronic back pain are not necessarily patients that need surgery unless they have spinal cord nerve compression, instability, or deformity, things that we can fix readily as part of our surgical treatment plan. These patients are, if chronic back pain would be, similar to giving antibiotics for patients who have fevers. We're treating a symptom, not necessarily a pathology or etiology that can explain their symptoms. And then, as I said earlier, even patients who may need surgery and meet the surgical criteria, there are still going to be patients that don't do well with surgery. And, many of these patients have chronic conditions that have anatomical factors that we can address, but they've already had severe or chronic neurological injuries or motor sensory loss that's not going to be reversible with surgery. So someone who comes in with spinal cord compression from a tumor or infection that hasn't walked for more than a few days and is in a wheelchair or bed bound, those patients are not likely going to benefit, at least from a neurological recovery standpoint. Patients with significant psychiatric comorbidities are very difficult for us to treat because, especially for chronic pain conditions, because those medical comorbidities ultimately have a major impact in how they do in terms of improvement or recovery from spine surgery. Unfortunately, there are patients with secondary gains, and this, can happen in certain situations. And patients with secondary gains will often find themselves in a situation where they might not need to get better, and they may not want to get better for their secondary gain, and it's hard to make those patients better from a functional standpoint. And then probably more commonly are patients who have severe or unoptimized medical comorbidity. So, patient that comes in with a surgical indication, they can't walk, but their hemoglobin A1C is 11. Those patients are going to have high risk for infection, post-operative non-healing, and other medical complications. Patients who have, undiagnosed or unoptimized coronary disease or osteoporosis are common examples we face with as we're treating more elderly patients in spine conditions. I think, for the most part, it's very important to recognize situations where it may require a more urgent or emergent consult because these are conditions that can lead to permanent and irreversible neurological disabilities. The spinal cord is pretty much essential for motor sensory function below our head. Spinal injury, depending on the pathology, can happen very rapidly or it can be insidious and progressive. But either way, when a significant amount of intrinsic injury has occurred in the spinal cord, there's limited regen or repair property of the spinal cord, limits recovery, and it's one of the things that we're trying to solve in our research. How do we protect the spinal cord? How do we regenerate the spinal cord? People have been working on this for decades with very little advances. So from a clinician standpoint, the most important thing is recognizing these situations where patients are at risk and prevent these situations from happening. So who gets these, urgent or emergent situations? Well, many of these patients are going to come in due to emergency or urgent care, but you will be surprised that these patients will actually show up in your office as, primary care treaters or even as physical therapists, because these patients may have tumors that are undiagnosed or they're not getting appropriate serious surveillance for the tumor. But typically, it's going to be trauma, tumor, infection, In some cases, degenerative condition in the cervical or thoracic spine that causes spinal cord compression. And there are some, a number of congenital diseases that can also progress insidiously and progressive that can lead to spinal cord compression injury that can lead to irreversible monosensory damage. This is just a slide showing you some examples of an MRI of a gentleman that presented to me as a transfer from an outside hospital with prostate cancer. In fact, he had just recently retired, never had a history of cancer, but had progressive back pain over an about 2 to 3 month period that kept getting gradually worse. He was being sent to physical therapy for treatment of back pain. He did not get any advanced imaging and ultimately presented to the emergency room where you can see he's got a high-grade spinal cord compression from prostate cancer. And, this patient actually did extremely poorly because he had not walked for over a week before he presented to surgery. And after surgery, he continued to be bedridden and had multiple complications related to his inability to ambulate. While he was able to fight his cancer for a while, he succumbed to his disease much quicker than the average individual would at 57 with prostate cancer because of the delay in the diagnosis of epidural tumor core compression from his prostate cancer. So these are the situations that you got to be aware and identify early. Again, prevention is really your best bet in making sure these patients, avoid situations like this. This is obvious. It's much more obvious. This is not someone that's going to show up in your primary care office, but it's a patient that had motor vehicle accident, presents to the hospital with, clearly a dislocated fractured spine. Even if and then occasionally people can have fractured spines that look this bad and they're still walking, but if you don't pick this up soon enough, they become, quadriplegic or paraplegic very quickly. And so again, these are what we would consider absolute indications when there are spinal cord compression or spinal instability or combination of both. So the typical presentation of these people, is actually not very subtle. They have significant pain. Their pain is not your typical, back pain patient that are sitting in your, clinical office. Generally, most of these patients are going to have some degree of progressive monosensory complaints. Pain is their predominant symptom, but they will gradually develop progressive monosensory complaints. And obviously, those are key elements to identify. The unusual symptoms are things that you ought to be looking out for spinal cord compression or colic syndrome. These are satellite anesthesia, bladder bowel incontinence. Obviously, bladder incontinence or stress incontinence is very common, but the combination of bladder bowel incontinence with satellite anesthesia, significant pain, are going to be a combination that you got to be looking out for these urgent and emergent conditions that may require treatments sooner than later. So in this situation, I think it's pretty straightforward. These patients should be treated in a setting that can be managed emergently or urgently. So emergency room with appropriate coverage in terms of neurosurgical or spine treatment. If you're in a place that doesn't have that, you can certainly call any one of us and we'll be happy to transfer the patient into our hospital to evaluate them for possible surgical evaluation and treatment. So most of the time, fortunately, you're not going to be faced with those emergent, urgent conditions. I think that for the most part, patients have a chronic condition that are going to present with some type of back pain, leg pain, or radiculopathy from degenerative processes or chronic conditions. I think in evaluating these patients, I think obviously doing good history and physical examination is part of it because you want to tease out these routine things away from the things that may have red flags and urgent conditions that you need to be careful about, paying more attention up front. I think that from a treatment standpoint, if you treat back pain or leg pain as symptoms without determining the source of their pain and pain generator, in my opinion, you won't have a whole lot of success in managing these patients in the long run, particularly chronic conditions. The acute conditions, we're fortunate that most of the patients are going to get better through conservative treatments. But for the chronic conditions, I think, as I said previously, you want to try to identify the source of the symptoms, not necessarily just treat the symptoms themselves. So from a surgeon's perspective, whenever I evaluate a patient with a back pain or leg pain condition, I'm trying to determine what is their pain generator, and can I localize those things to a certain, reasonable probability of certainty, and then target those things non-surgically first before I proceed with consideration for surgery. Most of the time, these patients have pretty benign course, so patient education and observation is a very reasonable medical management for people with acute back pain and radiculopathy in most cases. Physical therapy, interventional treatments are used very commonly. Not everyone needs physical therapy. Not everyone needs injections. You really have to tailor the patient's treatment based on the severity of the symptoms, the chronicity of the symptoms, the risk factors, and their expectation, as well as what is the likelihood that these treatments may provide relief. So if you send every patient with back pain to physical therapy, many of these patients that have back pain that can't even stand or walk from one to a couple steps are going to have a lot of trouble going to get benefit from physical therapy. In many of those cases, those patients will do much better getting some type of injection that can calm their inflammation or the pain generator down first before they proceed with physical therapy. Surgery is really the last treatment resort in most cases, unless you have an urgent condition or emergent condition, or in rare cases where patients have acute intractable pain that they're going in and out of the emergency or the hospital to get pain treated. But otherwise, we generally defer surgical treatment as the last treatment resort. And when we say last treatment resort, we don't mean, after, ANSID or Tylenol, or after physical therapy, after interventional treatment. If there are things that can help patients with their symptoms without harmful effects, in my opinion, people ought to try everything. So we encourage people to try, unusual, typical things such as atypical things such as acupuncture or chiropractic treatment. If they're being managed with their symptoms effectively without surgery and they're getting better, I think that's a win for the patient, at least from my perspective. So, this is pretty straightforward. I think history and physical examination is critical. I think that the more critical value of having a physical examination in history is that the history, in my opinion, for chronic conditions and spine condition is far more critical than physical examination, for your routine degenerative conditions. It's pretty rare that you're going to find someone with a true molar sensory deficit from a chronic degenerative condition. The exception to the rule would be patients with myelopathy, whether it's from cervical and thoracic spine. In those cases, a careful history and physical examination will always get you out of trouble. From a diagnostic perspective, I think that there are a lot of studies you can do. Insurances and and society is always going to tell you limit advanced imaging. You get X-rays and gap scan before you even consider MRI. I think while they're done for reasons that are appropriate from a healthcare spanning perspective, X-rays in general, it gives you very low yield in how you're going to manage that patient. If you're going to manage that patient with routine back pain for degenerative conditions, it's rare that X-rays are going to diagnose anything that you don't already know. And even with tumors, you have to have 50% demineralization of the spine before you're going to see any significant changes. So the X-rays are valuable when you're trying to identify a fracture that's obvious, that should be obvious in someone with osteoporosis or a trauma. Patients with misalignment like spondylolisthesis or deformity, you're going to see those on the X-rays. The CAT scans is very helpful for front bony architecture. So there are specific fracture patterns that you can detect on CT. And CT is extremely good for identifying those fracture patterns for bony architecture, but it is not very good to identify spinal stenosis, your typical radiculopathy. So getting a CT for the most part is generally a waste of money, even though most insurances and academic society will advocate getting a CT before the MRI. I think for someone who warrants a reasonable workup for their pain that's not getting better, the MRI gives you the most diverse and in-depth information you need to know about their spine from a spinal canal, neural element perspective, as well as even the bony alignment architecture. And then there are other studies that are used more rarely, like myelogram, bone scan, SPECT study, and then you heard a nice talk from Dr. Chang about the EMG nerve conduction study already. Injection and nerve blocks are often used for therapeutic purposes, but in fact, when you have identified a reasonable pain generator that you see on imaging or on your history, I think, injection and nerve blocks can be very helpful for diagnostic purposes from a surgeon's perspective. So we oftentimes will use them not just for therapeutics, but also for diagnostic purposes. So, I mean, it's important to understand that I think that, these diagnostics are really used in the appropriate context of the patient's, history and physical examination. So, when you think about it, if you get an MRI on asymptomatic patients, in most people after the age of 45, you're going to find something that's related to the degenerative process that doesn't explain their current condition. So you're going to overtreat things that are part of radiographic imaging findings without necessarily identifying, the patient's needs and the reason why they're there to see you. EMG nerve conduction study, Dr. Chang's already giving a really comprehensive and nice talk about this. It's useful for certain things, but many times it's not useful to diagnose something that isn't going to be picked up as part of the limitation of a electrodiagnostic study. So, our goal and my goal is to treat the patient. We try to identify what their symptoms are, what's the pathology or pain generator that can explain their symptoms, manage them as best as we can non-surgically, and then eventually, if there's a need and they're appropriate surgical candidate, we'll treat them with appropriate surgery. And our goal is to, treat the patient, not the imaging or not the diagnostic findings. So for the most part, your routine reasons for surgery is when patients have intractable, chronic, and severe pain, right? People that have pain for more than 3 months, that have mild pain, probably should not consider surgery. People with chronic, pain that's beyond 3 months, that's failed all your conservative measures, they can't work, they can't, do their activities of daily living. If they have an appropriate indication, I think those patients are reasonable surgical candidates. Certainly, patients with significant motor sensory symptoms should have a close evaluation for possible surgery. Pain and functional disability, they kind of go hand in hand. Again, those that fail medical treatment beyond 6 weeks to 3 months, depending on the condition, are reasonable surgical candidates. And again, as surgeons, we're not going to treat back pain. We're here to treat things that are going to get better with surgery, and those are pain or neurological symptoms and conditions that are associated with neural compression, spinal instability, deformity. So, as I've kind of said earlier, our spine center is pretty comprehensive. The type of surgery in any comprehensive surgical center is going to cover anything from, cervical lumbar degenerative conditioning, such as disc herniation, stenosis, osteophyte radiculopathy, certainly myelopathy with spinal cord compression, and then scoliosis, as well as kyphosis or chronic fractures. This is just a list of common spine procedures that you'll see and hear about. Most common procedure in spine is going to be microdiscectomy in the lumbar spine, followed by probably lumbar laminectomy or cervical discectomy and fusion. And then more uncommonly would be multi-level decompression fusions for either spinal listhesis or deformity. But generally, again, our goal is to treat neurocompression, instability, or deformity as part of these procedures. We, along with many advanced spine centers, are moving toward less invasive options as we do surgery. When we are able to do something through a small incision that's less invasive than the traditional open surgery, patients do better in terms of blood loss and postoperative recovery. So we use navigation, endoscopic approaches, and we're in the process of applying robotic assisted capabilities to help surgery become safer and better for the patient. And so there are many options that we have today that we didn't have 20, 30 years ago. And while it may seem like surgery is the same today versus in the 1970s, it's certainly not the case in most places that are pushing innovation, pushing the limits of what we can do surgically. So what should you or your patient expect in terms of outcomes for spine surgery? Number one, I think, our goal is to preserve or improve neurological functions when people have neurological symptoms, particularly when there are ridiculous symptoms. So nerve compressions with pain, these patients are going to do better because they're typically associated with nerve compressions, and with direct nerve decompression, people can generally expect, up in upwards of 80 to 90% improvement, and sometimes closer to 100% with particular pain symptoms, as long as they're presenting relatively reasonably early. Axial pain, back pain, neck pain is very different. You have to identify whether or not they have reasons for their surgery, and for the appropriate patients with deformity and instability, reasons to undertake a fusion. These patients are going to see pain improvement in a range of 50 to 70% in most patient population group. Occasionally, people can do better. Certainly, patients could do worse. But our goal is not to cure pain. Our goal is to make those intractable pain that's unmanageable, patients who are unable to function in the ADLs, patients who are dependent on chronic opiates that should get better with surgery. Those are the patients we want to improve. So 50% improvement for someone with true appropriate indication is actually a very significant benefit. There are actually few things that can achieve that, but the key thing is, again, finding the appropriate indication that's going to get better with surgery. So